Hey guys, I was at the end of my video and then I realized I didn't press record. So I'm going to be doing COPD in 5 minutes or less. So again, with the patho, we're just going to start. Remember, COPD, what is it? It's a chronic inflammatory disorder. So I know you're like, okay, what's the difference between COPD and asthma? If you'll remember, asthma creates bronchospasms. It still has that inflammation, but with COPD, you see bronchoconstriction. So you see that constricting of the bronchioles and inflammation too. So what does this lead to? It leads to chronic bronchitis. And the biggest thing to remember with that is there's that hypersecretion of mucus. So you do see some mucus in asthma patients, but nothing like this. That's a huge thing to remember with COPD. And then emphysema, that's that air trapping. So you have less airflow with expiration. So you're gonna see a lot of difficulty breathing with that. So again, bronchitis, mucus, and then emphysema is difficulty breathing. So how are you gonna assess your patients when they come in? You have to look if they've had more than 3 months worth of symptoms, which I will get into in a second. And then you're gonna do a forced expiratory volume test. Stage 1, it's very similar to the asthma, but the numbers are a little different. Stage 1 is 80% or more. So that's that's what you're aiming for. That's like a perfect score. Stage 2 is 50 to 80%. So again, you're gonna look, should I modify their lifestyle? Is there any way we could do modifications with that or with their treatment plan? Stage 3, 30 to 50%, that's when you need to administer a bronchodilator ASAP. And then for less than 30%, this is considered end-stage COPD. So you're going to want to provide the patient with a lot of comfort and information on end of life. So back to the symptoms. So again, as I said in patho, it causes that bronchitis, that chronic bronchitis, which is that mucus, that hypersecretion of mucus, and difficulty breathing. And then the other part of the patho is it causes emphysema. So with that, you're going to see in a patient a cough, they're going to have difficulty breathing, a barrel chest, they may have pursed lip breathing. So remember, emphysema is that decreased airflow, the air trapping, and chronic bronchitis is that hypersecretion of mucus. And so the cardinal signs you will see is a cough, a sputum, or sputum, whatever, how you pronounce it, and exercise intolerance. So any kind of physical activity will be hard for these patients. So again, you're gonna wanna assess them pretty well with doing that forced expiratory volume, or you can even do pulmonary function studies. There's also other tests, ABGs, and just looking at those levels too. So then finally, the risk, what puts a patient at risk for getting COPD, smoking. That is the biggest thing that we talked about in class that we need to remember, because smoking causes vasoconstriction. This causes constriction. So if both those together, you're gonna see a patient have even more difficulty breathing. Asthma and environment. So is there a lot of pollutants in the air or chemicals? So just remember that. So finally, how are we going to treat it? So the first line of defense for COPD is inhaled steroids. So fluticasone, I'm horrible with names. That is going to be the first line of defense. That's what we need to know is really important to use. Now, if a patient doesn't respond to the inhaled steroids, you're going to use an inhaled anticholinergic, which is ipratropium. That's another bronchodilator that can be used instead of this if the patient doesn't respond, or it can be used with it. And then a leukotriene modifier, and it's Zeruflocast. I need to learn these better. But nonetheless, those are the 3 things you're going to use with treatment of COPD and nursing interventions. Just remember, they have a lot of difficulty breathing, so ineffective airway clearance, impaired gas exchange, ineffective breathing pattern, and just, anxiety, helping them with that. So here's COPD. I hope that makes it easy.